Good afternoon. My name's Molly, and today we're going to work on an iSABR in an emergency situation code blue simulation. Just to talk about simulation a little bit, simulation resembles reality but is not real. We ask that you focus on solving an evolving clinical situation in the simulation room and work together as a team. This is a safe, non-punitive environment. Where learning therefore happens as it evolves. What happens in the simulation room stays in the simulation room. So we will talk about it in a debriefing session, and it's used as a learning tool. Everyone can agree that simulation is confidential?
Mm-hmm.
Yes, thank you. We operate under the assumption that we're all here to learn and do our best and help our patients and our veterans. This is not an evaluative process at all. I'd like to create an environment of psychological safety where you feel safe making making mistakes, and we're all expected to learn from them. As I said, we realize that simulated environment is somewhat different than what you're used to. So in different situations, in the simulation room, you might verbalize what you're doing instead of actually doing it. Like I would start an IV if it was an appropriate time to start an IV. And that'll make a little bit more sense after you have orientation to the simulation room. It's closed environment where we like to use closed loop communication as a gold standard. If there's at any time during the simulation you feel uncomfortable, please, we're going to use the word halt. Say that word and the simulation will stop. Everyone will freeze and bring their attention to that person. And again, we'll talk about and debrief about what's uncomfortable in the situation so we can move forward or just end the simulation altogether. Are there any questions at this point?
No, I'm good.
Okay. So this simulation is, as I stated, an iSABR in an emergency situation or code blue. Suja, you're going to be nurse 1 or
Okay.
rescuer 1, and Kathy, you'll be rescuer 2.
Okay.
What I'd like to do is give you an iSABR report on your patient.
Mm-hmm.
The expectation will be after the orientation to the room that you go in and provide care to this patient,
Okay.
utilizing your iSABR tool.
Sounds good.
Okay. So the patient is Henry Wall. He's a
Mhm.
75-year-old gentleman.
Mm-hmm.
He presented to the emergency room yesterday with shortness of breath,
Mm-hmm.
chest pain.
Mm-hmm.
He has a history of end-stage renal disease, and he is an insulin-dependent diabetic.
Mm-hmm.
On chest x-ray, he had bilateral pulmonary edema,
Mm-hmm.
and he was given some Lasix in the ER
Okay.
and is oliguric.
Okay.
Please, if I'm going too fast, just have me slow down.
No.
He had a cardiology and nephrology consult.
Mm-hmm.
They did place a dialysis catheter,
Mm-hmm.
and the plan is to dialyze him this morning. He is a full code,
Mm-hmm.
and his admitting diagnosis was an NSTEMI,
Mm-hmm.
congestive heart failure, acute on chronic kidney failure. He has no known allergies. His vital signs have been stable. The last set were 175/94,
Mm-hmm.
respirations of 22,
Mm-hmm.
heart rate of 82.
Mm-hmm.
On admission, he was in a normal sinus rhythm with no ST elevations or T-wave inversions.
Mm-hmm.
And throughout the night, although he's still in a sinus rhythm, he has peak T waves and occasional PVCs. He's afebrile, temperature of 97.4, and he's 95% on room air, and he complains of no pain. His
Yes.
lung, pardon?
What's his oxygen saturation?
95% on room air.
Okay. Thank you.
He's got non-labored respirations, bilateral chest expansion. He has fine rales at the bases bilaterally, and no acute shortness of breath or respiratory complaints.
Okay.
He had a blood sugar of 245 at HS last night, and he got sliding scale coverage and Lantus as ordered.
Okay.
He's NPO.
Okay.
His abdominal assessment is benign. Last known bowel movement was the day before he came in. He has a number 20 peripheral IV in his right forearm and a double lumen dialysis catheter in his left upper chest. Dressing is clean, dry, and intact. His morning labs just came back. His Sodium was 140,
Mm-hmm.
potassium 7.9, creatinine of 13.2, BUN of 110, and his H&H are 6 and 29. And his troponin was negative.
He's very anemic. Okay.
And as I said, the plan is to dialyze him this morning, and the doctor is aware of his morning labs.
Okay.
Okay?
Sounds good.
Do you have any questions?
No.
All
You
right.
have given me everything what I need.
Okay, thank you. So now we're gonna go into the simulation lab, and I'll give you a sim lab orientation. This is Henry Wall, our high fidelity mannequin that we'll be using today. The hospital bed operates with the remote right here, or the keys on the side if you need to move the bed up or down, or the head of the bed up or down. The head wall on the back, there's an ambu bag if you need it, and the oxygen does not work, so you would verbalize, I'm turning it up to 10 liters, 15 liters, however many liters you feel appropriate for the simulation.
And this patient is not on oxygen at the moment.
He is currently not on oxygen, correct. On the side over here are some gloves and some hand sanitizer.
Okay.
And off to my right is a code card if you should need that as well. Do you have any questions?
That is a cardiac board at the back of the code card.
Yes, there is a CPR board on the back, yeah.
Okay.
Okay, excellent. We'll step out into the hallway, give you a few minutes to gather your thoughts. Suja, when you enter the room, the simulation will begin.
Sounds good.
All right, thank you.
All right. Will do. Hello, Mr. Henry. My name is Suja Thomas. I am going to be your nurse today. How are you doing? Let me just check and see your name, Henry Wall, and your date of birth is 318XX. Very good. Henry, are you doing okay? Henry, are you doing okay? Henry, Henry, are you okay? Are you okay? No pulse, no respiration, it's not breathing. Kathy, can you please dial 62911?
Okay.
Call
let
the
me do
code
that.
and get a code card.
I've called for the code. The team should be on the way. Here's the crash card.
Just get this done.
Hit the CPR button.
There we go. 1, 2, 3, 4, 5, 6, 7. Yeah, put the code underneath. Okay.
Let's move the bed so I can get to respirations.
1, 2, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Kathy, get the bag ready. 17, 18, 19, 20, 21,
Hi.
23, 24, 25.
I heard the code on the team leader.
29,
Can you tell me
30.
what's going on?
Kathy, give the 2 bags. My name is Suja Thomas. I am the nurse for Mr. Henry Wall, and while he was a visit here the other day, he came in with end-stage renal failure, congestive heart failure, and also had diabetes. And
Yeah,
he's
continue
right now-
CPR.
he is actually, he had a cardiology and nephrology consult. He's supposed to have dialysis this morning. He had a dialysis catheter in his right upper chest wall. And in the chest x-ray, he had bilateral pneumonia. And then he did also had, in the EKG, it was showing he had a peak T wave. And he had occasional wheezing, and his blood pressure was normal earlier, but when I came into the room, he was found unresponsive.
Okay, did he have labs this morning?
He did have his labs. He had his potassium that was actually 7.9. His creatinine was 13.2
30,
and
30.
30, and his blood urea nitrogen was, thank you, and his HLH was 6 and 29.
Okay,
All right.
and what have we done? Just,
So when I came in, I started the CPR, and we are doing the airway and the CPR. We finished 2 cycles of CPR at this point.
okay, we're gonna get the
30.
pads on him.
30.
Can you assist us with that?
Yes.
Because you are the code team
Yes.
leader and there's only
5,
2 of
6,
us.
Yep,
7,
all right.
8, 9, 10.
Sim is ended.
Sim is ended. Okay. How's everyone?
A little bit tired.
Just tired after the code.
Okay. So how, if I can ask the group, how do you all think it went?
I think it went pretty good.
Yeah.
And I went to the room. I found he was unresponsive. I checked for responsiveness. There was no response, and immediately called Kathy and to dial 62911 and call the code and get a code card. And I started CPR right away. And as soon as Kathy came in, she was actually, putting the cardiac board underneath the patient. She pressed the code button so in order to get the bed flat fully. I was able to bring the bed down, but the button was on the other side. I couldn't get to there, So I was on the chest, and she immediately put the ambu bag and started doing the airway. So the thing went smoothly, and the physician walked into the room, and we had to debrief. And it is very hard, a person doing the CPR trying to do the, giving a scenario of what's going on too. So I was able to give the gist of the scenario, what was going on with the patient. And that's where we ended the scenario.
Okay. I did see that when you were trying to give report, you did pause doing CPR because the challenge of talking while doing
and
CPR.
while doing that, yeah. Because you can't focus both things at the same time.
But with a gentle reminder, she just picked it right back up, just like we would do in real life.
Yeah. And also, Kathy, I noticed that you advocated for help from the provider.
Yes. Well, it's difficult with just two people.
Right.
A minimum of 3 is really necessary.
Yep.
So thankfully, the provider was more than willing to assist.
So leading from behind, that's a really good thing to do, just gently asking for help. Is there anything overall that you think could have been done differently in the simulation, taking care of the patient? Or that could transcend into a real life situation?
Definitely. So when I knocked at the room, I went to the room. I could have provided some privacy, closing the curtains. I washed my hands using hand sanitizer, but I did not put on the gloves because the need was immediate. I didn't have time to put on the gloves, so I had to get on the chest, which I did not. I should have done it.
I didn't have time for gloves either. It's emergency.
Yeah.
Okay.
So that is something that we could have improved, and it would have been nice to have another third person in the room to be helping when Kathy came in. I wish somebody would have been there.
Yes.
When it's lunch break time, people must have been on break. We didn't have enough people to help us.
Or in another patient room.
Correct. And I was tired when I was doing the first 2 minutes of CPR, and then second cycle started, and you walked in, and I was kind of panting when I was trying to give you the report, and then I'm trying to focus what I'm trying to give it to you. So critically thinking, whereas I'm trying to do the CPR, it was not well coordinated at that point.
Right. And the scenario
there was
as
a
it
gap.
rolled out was that you had just gotten a report on your patient, so you really had a very short period of time to kind of absorb the report you got and process it.
I didn't even do any assessment on the patient other than just checking the responsiveness.
You did do the assessment. The assessment was they were pulseless and breathless, and we needed to do CPR.
Absolutely. There was no pulse, no respiration. So we had
That's
to get
a full assessment.
Right.
So if you had to venture a guess, what do you think the learning objectives were for today's simulation?
Basic life support implementation.
Okay.
And utilizing the iSABR, giving a proper report to the physician when they were coming in.
Oh, okay.
Okay.
Also.
All right, excellent. Just to conclude and summarize, I think that what I'm hearing is some of the things that went well. It sounds like there was some good teamwork in the room, some good closed loop communication, abdicating or leading from behind to, remind the provider they were the third set of hands. So I think that was great. The learning objectives were all touched on in terms of recognize the patient was unresponsive, calling for a code, using the policy, the code blue, dial 62911, and then giving an SBAR with the pertinent information to the provider so they can start to care for the patient and have a general understanding of potentially what could have caused the situation.
Okay.
Do you guys have any other questions or comments?
Are we going to do more of these? Because these were really fun.
Yes, we are.
Yay.
Thank you.